Namaste everyone. Welcome to the YouTube channel of Shree Swaminarayan Physiotherapy College, Ahmedabad. Here, I, Dr. Tirtha Panchal, will discuss about the physiotherapeutic management of burns. I had experienced that many of medicos and laymen don't know the possible physiotherapy treatment after burns and its importance. So today I will give knowledge about physiotherapy management post burns somewhat in detail. Subscribe our channel for more informative videos. So let's start with our today's topic, that is burns and physiotherapy management. Contents for today's topic is what is burns, definition of burns, epidemiology, types of burns, its management, what precautions should we take, medical management, and finally our topic, physiotherapeutic management. So a burns is an injury to the skin or other organic tissue primarily caused by heat or due to the radiation, radioactivity, electricity, friction, or contact with the chemicals. This definition is given by WHO. Burns is defined as a wound caused by exogenous agent, that is agent from outside, which lead to coagulative necrosis of the tissue. Epidemiology of burns. Burns are a global public health problem, accounting for an estimated 1,80,000 deaths annually. Per year, this much deaths occur due to the burns. The majority of this occur in low and middle income countries. Burns are among the leading cause of disability adjusted life years, that is DALYs, and in India, in our country, over 1 crore people are moderately or severely burned every year. This data are till 2018. So now types of burns. First is scald, which is caused by a hot liquid. Mainly children or young age people are affected by the hot liquid pouring on the hand or on the feet. Friction type, that is caused by rough surface, friction or severe friction between two surfaces. For example, carpet which is having spikes on it. Radiation or sunburn, which you all know. Electric burn. Specifically in this type of burns, there will having an entry of burn and an exit of burn. So you can see two injured part in a body of a victim. Chemical burns, that is due to any chemical contact to the skin, and dry burns, that is touching of hot object. For example, cooker, which is very common in housewives. I'm not going much in detail in of classification of burns and that calculation of body surface area of burns and that all equation and all. Directly jump to the management part. So management of burns is not possible by only one member or any two members. It's a team approach. So in a management of burns patient or a victim, team approach is taken. In this team, physician, dermatologist, burn specialist, and surgeons are included. Nurse to be taken care of. Physical therapist. Yes, physical therapist is inevitable member of this team. Occupational therapist for further vocational and occupational rehabilitation. Speech therapist if specifically upper body is affected due with the burns, and social worker. For management of burns, the ABCDE approach is taken. First, to check A is airway and oxygenation. It is mainly checked in burns or fumes which are inhaled during the burns. Second is B, that is breathing and ventilation, if it is hampered or not. Then check circulation and shock management. Usually it occurs that after burns or after the incidents, patient's body go into shock. So, is there any severe burns which causes body to be in shock or not? D is disability due to the neurological deterioration. Usually, post burns, disability occurs, and if the burns are deep enough and if it affected nerve parts or nerves, then neurological deterioration occurs. And last is E, that is exposure and examination of the part. First aid for burns. First is cool, second is cover, 3 is C, that is 3C protocol. Put part in cold water under the running water specifically, cover the burnt area and call emergency assistance. Survival tricks for burns. If layman catches the heat specifically or fire, what to do if your clothes catch fire? So first is stop, second is drop, third is roll. So SDR is a short form to remember this. Stop where you are if your clothes caught fire, then drop or fall down on the ground, and third is roll. Cover your face with hands before start rolling, and then roll on the ground so that the burnt area or the fire will get diminished. First aid for burns and scalds, that is stop. S is for strip. Remove your hot clothes and jewelry if possible at that time only. Turn on cold tap as we have seen earlier. Put your affected part under the running water, cold running water. Organize, that is call for immediate medical assistance or help, and protect burnt area with simple clean cloth. No extra blanket or dressing or anything should be done. Now physical therapy. Common impairments which are usually seen after burns are pain, obviously first symptom or first impairment, impaired skin integrity and impaired sensations. Skin congruency or skin integrity is affected, and sensations if the burns or the depth of burn is deeper. Edema, that is due to fluid accumulation. Muscle weakness due to post burns, prolonged bed rest or prolonged immobilization phase. Impaired joint integrity if the joint is affected in the incidents or in the burns, and impaired breathing. Mainly fume inhalation is there in breathing portion. Now impairments, there are few examples of injury-related impairments which result in disability in shorter or prolonged period of time. That is physical and or cognitive limitations due to neurotrauma, paralysis due to spinal cord trauma if the complete back portion is affected, then partial or complete amputation of limbs if the distal portions of limbs are completely burnt or severely affected, then the amputation is only choice of treatment. Physical limb deformation resulting in mobility impairments, like as we discussed, if joint is affected or if burns area is such that or larger area of burns is there which requires prolonged bed rest, so mobility will hampered. Psychological trauma, and here the role of social worker is coming. And sensory disability such as blindness and deafness. If the facial bones occurs, then disability of blindness and deafness can occur. As we all know, it is said that prevention is better than cure. So prevention strategies should be address the hazard for specific bone injuries, specifically education for vulnerable populations and training of communities in first aid. Many people, और हम कभी कभी ऐसा देखते हैं कि कभी किसी विक्टिम ने या किसी बच्चे ने या कोई भी पर्सन जिसने फायर कैच कर लिया है और वो जल रहा है, तो कम्युनिटी में से कोई हेल्प करने नहीं आएगा या फिर किसी को उतनी समझ नहीं है कि वो उसको हेल्प कर पाए. सो ट्रेनिंग ऑफ कम्युनिटीज इन फर्स्ट एड इज़ वेरी इंपॉर्टेंट. Promote safer cook stoves and less hazardous fuels, and educate regarding loose clothing or wear loose clothes while cooking. Apply safety regulations to housing designs and materials, and encourage home inspections on regular or frequent period of time. Inspections should be taken. Improvement or improve the design of cook stoves, particularly with regard to stability and prevention of excess by children. बच्चों में ज़्यादातर यही देखा जाता है कि जैसे गर्म दूध पड़ा था या फिर गर्म दूध गैस पर से खुद से लेने के लिए गए और तब जल गए, या फिर गर्म पानी उनके ऊपर गिरा और तब जल गए. सो दिस इज़ वेरी कॉमन. लोअर द टेम्परेचर इन हॉट वाटर टैप्स. चेक करने के लिए हाथ डाला और जल गए. गर्म पानी आ रहा है कि नहीं यही देखना था सिर्फ. दिस इज द इंसिडेंट. प्रमोट फायर सेफ्टी एजुकेशन and the use of smoke detectors, fire sprinklers and fire escape system in homes. ज़्यादातर हमारे सेटअप में नहीं देखा जाता कि फायर एस्केप सिस्टम घर पे भी हो, या फिर सेफ्टी डिवाइसेस लगा रखी है जैसे स्मोक डिटेक्टर्स या फायर स्प्रिंकलर्स है, लेकिन वो चलाना नहीं आता, यूज़ करना नहीं आता. सो education for that is required. Promote the introduction of and compliance with industrial safety regulations and the use of fire retardant fabrics. Industrial safety is also very necessary. Avoid smoking in bed and encourage the use of child resistant lighters. Smoking in bed is very dangerous. Improve treatment of epilepsy, particularly in developing countries, and encourage further development of burn care system. Support the development and distribution of fire retardant aprons to be used while cooking around an open flame or kerosene stove. कई बार ये हिस्ट्री मिलेगी आपको कि केरोसिन स्टोव यूज़ कर रहे थे, एकदम से हवा चली और फिर पर्सन या स्पेसिफिकली हाउसवाइफ को बर्न्स हुआ. There are few basic goals which were given by APTA. It is difficult to list specific outcomes because of varied nature of each burn injury. As we have discussed earlier, the types of burns. So according to the type of burn or injury of which caused burn, that are very huge, or there are very different types. So heat or for say scald does not require or should not be treated equally for the radiation burns. So first goal would be wound and soft tissue healing should be enhanced or is enhanced. Risk of infection and complications is reduced. In burns specifically, complications or risk of infection is much higher. So third will be risk of secondary impairments are reduced. For example, due to immobility, the contracture is developed, or the skin integrity will be hampered. So the secondary impairments occurs. So the risk of that should be reduced. Attainment of full joint range of motion, that is after positioning, when the part is allowed to move, immediately start passive at least exercises of joint or a part. Restoration of pre-injurious level of cardiac endurance. Cardiac endurance is very hampered, or let's say is commonly hampered post burns. uh, I will go in three phases of rehabilitation post burns. First is acute phase, second is subacute phase, and third is chronic phase. So let's discuss about acute phase first. In acute phase, the patient will be uh, in a phase of inflammation. So immediately after injury of burns, the patient falls in this phase, and the inflammation is there. Pain, severe pain is there in acute phase. Edema increases, start increasing up to 36 hours post injury. Hypermetabolic response peaking at 5 days post injury. Metabolism is increased and increased. Early synthesis and remodeling of collagen fibers. Remodeling starts immediately after injury occurs. The aims in acute phase will be reduce the risk of complications or the infection. So proper dressing should be there. Reduce edema, particularly when it poses a risk of impingement on peripheral circulations or the airways. So elevation or positionings will be given. Predisposition to the contracture. So no any just for example, like if the affected area is around the elbow, so elbow should be in complete extension. If it will be in mild or somewhat in flexion, contracture will develop around the cubital fossa. Prevention of deformities and loss of range of motion, and protect the healing or affected area and promote the healing. These are the common treatment techniques for immobilization and positioning. You can see here the body areas which are affected in burns, contracture predisposition. So, and the preventive positions. So, if the limb or the affected part is kept in contracture in positions which predisposes contracture, it should be contraindicated. Uh, for example, first is neck. So neck shouldn't be in flexion. It should be, or the preventive position of contracture for neck is extension or hyperextension. So the interior portion of the neck will be in complete extension, or skin is completely stretched. So there is no chances of contracture to be developed. In anterior axilla, it should be the shoulder should be in abduction. Antecubital space, that as I have told, elbow should be in complete extension. Forearm should be supinated, or else the pronation contracture will develop. Wrist should be in complete extension. Fingers, that is MCP, PIP, DIP joint should be in complete extension and radial abduction. Coming to the lower limb, hip should be in extension, abduction and neutral rotation. No internal rotation or no external rotation. Knee should be completely extended. Ankle should be completely dorsiflexion, completely dorsiflexed. So otherwise commonly plantar contracture is developed in and around the ankle. Dorsal toe or dorsal toes should be flexed and the plantar toes should be extended. These are the immobilization of hand and degree at which the joint should be kept in position of safe immobilization by Glassy in 2004. It is described as wrist should be in 30 degree of extension. MCP joint that should be in 70 degree of flexion, and PIP DIP should be straight. So no any flexion should be occur at that point. And for this, the splint or static splint is given, that is thermoplastic Palmer static splint. You can see the blue static splint over here. Now, sorry. Similarly, the dynamic flexion hand split in glove form. This should not be given in acute phase. So mobilization should not be as much that the limb or the pain or affected area is increased. And these are in figure 1, dynamic extension hand split. So it will allow the movement to be in extended. Okay, management of edema. Elevation, as you all know, elevation of the limb, carbon wrap, and edema glove or DG sleeves. I'll show you later on. These all are reduce the edema, or the limb should be in elevation position such that the gravity will assist the lymphatic drainage. These are the gloves and the digi sleeves for digits. Yes, you all know this. This is the airplane splint for axillary or chest or the limb burnt injury. In anterior axilla, we have discussed earlier in the preventive positions. Hand or shoulder should be kept in complete abduction position. So in anterior axilla, the flexion or adduction contracture will not develop. In second phase, that is subacute phase. So rehabilitation in subacute phase. Beyond the acute stage of immobilization, inpatient and outpatient rehabilitation typically consists of variety of interventions which are included. That is pressure garment therapy, silicone therapy. We will discuss this later on. Pressure garment therapy, silicone therapy, scar massage, range of motion, which is started now. Mobilization technique, strengthening of the affected area, functional and gait training should be started in subacute phase. Balance and fine motor training if it is affected. Keep in mind this, that interventions should be tailored according to a full patient assessment. There is no such protocol which is fixed that in this type of burns or in this affected area burns, this all the protocols and you have to follow this only. Patient to patient treatment is varied. So intervention should be tailored after full patient assessment. The patient in acute phase will be primary closure of wound is set. Scar is in remodeling phase now, and scar will start contracting as well. So what should be the aims in subacute phase? Optimizing the scar appearance. That is, if it is cosmetically important for many people, so start work on it. Limit effect of scar contracture or prolonged positioning on range of motion and function. Address effect of prolonged bed rest. There are many complications or secondary impairment which will cause due to prolonged bed rest, so address it. Common modalities which should be given or which can be given in subacute phase. These that are for mobilization, both mobility and specific joint mobilization. Mobility in general, body as a whole, and particular joint mobilization, for example shoulder mobilization or knee or so. Scar management, very important. Pressure garment like silicone and scar massage. We will see this in next slides. Continuation of edema or positioning management if necessary. If edema is still there, or if it persistent, or if it comes after some time, then the management for edema if will be continued in this phase also. Okay, now mobilization. Burns patient should be mobilized as early as possible to avoid deconditioning and possible respiratory complications which are associated with prolonged bed rest. Patient's lung capacities will reduce, patient's general skeletal system or muscular mass will affected, patient's strength will reduce. So this all are complications associated with prolonged bed rest which should be addressed. Active range of motion, start with gentle range of motion exercise, and which is more or most effective means of reducing edema. Not only positioning will reduce edema. If positioning is remote, or let's say the elevation which is given to reduce edema which will remove, so there may be chances of recurring of edema. So muscle pumping movement or muscle pumping exercises will also reduce edema by active muscle contractions. Passive range of motion, which is contraindicated in this phase but can begin during the scar maturation phase once the scar tissue has adequate tensile strength to be tolerate friction or to tolerate the movement of a muscle which is caused by mobilization technique. Let's say, or let's take an example of knee joint. If the burns occur around the knee joint and at the knee joint, if we start doing passive exercises, so in complete flexion and extension of knee, the anterior portion of the knee, or let's say the patellar region skin will be in friction and the scar is not completely healed. So the scar remodeling which is already occurred will hampered, and again the scar will open. So we don't need to do that. So it should be implement once the scar is matured or the scar is in maturation phase also. Frequency and duration. So one will ask that when to how many times we can give mobilization to the patient, or for how much time or duration. So active exercises is we can give twice a day, that is enough. And also we can ask patient to do active exercises whenever he or she feels comfortable, and passive exercises once prescribed or once allowed 3 times a day, but start very gently. Depend on the severity of the burns, active and very gentle passive range of motion exercises for the hand and fingers are begin from day 1 of the injury, but that is completely dependent on severity of burns. Let's see now scar management. Most common complications of burns injury with estimated prevalence of more than 70% of those who suffered burns injury. Not only do hypertrophied scars, which cause psychological difficulties through their cosmetic appearance, as we have discussed earlier, they may also be painful, pruritic, that causes pause exploration, and that may limit range of motion where they occur or on or near a joint. So it will limit the range of motion also due to the pain or pus collection or so. Pressure garment therapy. Okay, now maybe you have seen patients post burns or in rehabilitation phase after burns injury. They are wearing pressure garments. So what is the minimum pressure which is required to give effect of this pressure therapy? So minimum of 15 mmHg of pressure is required to see changes or to obtain changes, and if the pressure is more than of 40 mmHg, it can cause complications. Time of or time for pressure garment therapies, it should be or it can be worn up to 20 to 23 hours per day, with removal for cleaning of the wound or and or garment, and moisturization of the wound protectors. Duration, it can be worn as soon as wound closes and the scar is stable enough to tolerate the pressure of the patient garment. So it can be started. Post grafting, if the skin is grafted or the burnt area is grafted, then it should be started after 14 days or wait till 10 to 14 days, and then discuss with surgeon, and then it should be started. Garment should be worn for up to 1 year or until the scar maturation is completed. These are the different pressure garment therapy, pressure garments for pressure therapy for different joints or different body parts which are affected. You can see in first photograph there is hypertrophied scar, but patient has taken the therapy or pressure therapy for up to around 10 to 12 months using pressure garment, and after the compression therapy, in the third picture you can see the scar or the hypertrophied scar is reduced. Now scar massage techniques. There are you must be already learned the massage techniques, particularly for scar. So retrograde massage to aid venous return, increase lymphatic drainage and mobilize the fluid. Effleurage to increase the circulation. This is very important massage technique. Static pressure to reduce pockets of swelling. In distal portion of the burn area, commonly it is seen that there is swelling pockets. You can see the small areas of swelling, not the whole part is swollen. So to reduce that pockets, static pressure is applied. Finger and thumb kneading to mobilize the scar and surrounding tissues, and to stop scar to be adhered below. Skin rolling massage to restore the mobility and restore the mobility to tissue interface. Ringing massage and friction massage to loosen the adhesions and stretch the scar. These are the guidelines for massage during 3 stages of healing. As you all know, there are 3 stages of healing: inflammatory stage, proliferative, and remodeling phase. In inflammatory stage, gentle massage to decrease the edema and increase blood supply. In proliferative phase, massage with gentle stress to healing scar, which will enhance the collagen to be aligned correctly. In remodeling phase, massage should be processed to include prolonged stretching to minimize the adhesions. Now last phase is chronic phase. The patient in chronic phase will be in healing process which may continue up to 2 years, and as the scar tissue remodels and matures completely. Patient may require functional training and integration back to the community and its before injurious level activities. Or it is very important that patient should achieve or achieved near to his pre-injurious level status. So that is vocational rehabilitation is very important in chronic phase. It is important to note that tough scar management is initiated in subacute phase, and it may needed to be continued long term, as if the larger portion is affected or larger scar is there on a body part or joint is affected. So scar mobilization or scar management will also continue in chronic phase also. Pressure therapy, laser therapy, and combination therapy can be given in this phase. Rationale for aerobic and resisted training, both can be given in two different ways to achieve two different goals. It is proposed that aerobic capacity and muscular strength is diminished by the following factors. In patients with burns, that is prolonged bed rest necessary in the early recovery phase, which reduces many, as I told you, that lung capacities are reduced or muscle strength is reduced, muscle mass is reduced. Next is hypermetabolism, which may lead to exhaustion or early exhaustion. So that can be managed. Protein catabolism, loss of lean body mass, impaired thermoregulation and inhalation injury, which compromise the respiratory functions. And recovery of aerobic capacity and strength may also be limited by fatigue. Early or easy fatigability in patients are seen, pain if it is persistent, and many psychological factors. Now, what to do and what not to do. So, I tried to cover almost all points, what to do and what not to do, so that everyone can understand or get to know. What to do is immediately stop the burning process by removing the clothes if it caught fire, and or irritating the area which is already burnt. Extinguish flames by allowing the patient to roll on a ground. We have seen earlier in that image, that is, put your portion or put your affected area under the tap water, then cover it and immediately call for help, or the fire is there, stop where you are, fall on ground and roll. Cover your face with your hands and then roll. So it will immediately stop the contact to the skin, or the heat or the flame will not in contact for prolonged period of time. Use cool running water to reduce the temperature of the burn, not covering the burnt part with like blanket or with the towel, and so immediately put your affected part under the cool running water to reduce the temperature of the area. In chemical burns, remove or dilute the chemical agent by irrigating the large volumes of fluid. Immediately put the affected part or the part which is in contact with chemical agent under the running water. So all the chemical agent which are in contact will wash out. This should be done. Now, what should not be done or what not to do? Never ever apply paste or oil or turmeric or haldi, even or raw cotton, to on the or over the burnt area. It may cause the infection or direct infection to the affected part. Do not start first aid before ensuring your own safety. Like in electric burn, if you see a victim, don't touch him or her immediately. Switch off the electric currents first. Wear the safety gloves or any like A wooden object should be used. Do not apply ice because uh, it deepens the injury. I always say or told the patients that जैसे हम गर्म चीज़ या ज़्यादा गर्म चीज़ से जलते हैं वैसे ही हम बर्फ़ से भी जल सकते हैं, जो ज़्यादातर किसी को नहीं पता है. So it can deepens the injury. Avoid prolonged cooling with water because it will lead to hypothermia. The temperature of that particular body part or a body as a whole goes in hypothermic shock. So the immediate body temperature will reduce and body goes into shock. So that should not be done. Do not open the blisters until topical antimicrobial can be applied, such as by a healthcare provider. ऐसा बोला जाता है कि जैसे बर्न्स होने के बाद जो पानी भर जाता है तो उसे निकाल देना चाहिए या उसे फोड़ देना चाहिए, ये नहीं करना चाहिए. These all are the references for this lecture. If you want to read further or read in detail more, you can refer this books and articles. Many have doubts that मतलब फिजियोथेरापी या फिजियोथेरापिस्ट का कहाँ इतना रोल है बर्न्स जैसे केसेस में, बट नहीं, ऐसा नहीं है. वी डू हैव रोल इन बर्न्स रिहैबिलिटेशन. Thank you for listening me.